Hi, everybody, and welcome to this edition of Taking Control of Your Diabetes, or TCOID Live. I am one of your hosts, Dr. Jeremy Pettus, joined as always by my good friend and colleague,
Steve Edelman.
Yes. So if you're tuning in, this actually is live. So what you see is what you get. But we will, of course, rebroadcast this. So you'd be welcome to share it with other people, etc. And I have, by the miracles of technology in front of me, questions that you guys are entering on whatever platform that you're watching, kind of funneled here to my computer. So as you're watching or thinking of things, please, write down your questions, because the name of the game here is this is a Q&A. And we're going to get through as many questions as we can in the time.
Yeah. And today's theme is type 1 diabetes. We alternate every quarter with type 2 questions. So today we have a ton of questions already from many of you folks with type 1. You should you should all know that Jeremy and I both have type 1. So and we're both endos. So there's no one better to do this live Q&A with the endos.
If you want to turn this into a drinking game, take a shot every time Steve hits the mic, because he does it quite frequently.
So that's just one.
That's just one that if you're keeping score at home. So, all right. So here are the questions, and some of these I might try to paraphrase because they're on themes and things like that, and to make them more generalizable to kind of everybody. And these are obviously in no particular order of importance, but let's get into it. So one of the first ones is about the Medtronic system, the 780G. And it asks, is the Abbott sensor out yet? And this is kind of hot off the press. So I actually use a Medtronic pump, and for the longest time, you had to use their Guardian sensor, which is accurate, but very outdated in terms of you needed a separate, that's another shot, a separate transmitter to put into the to the device. You had to charge the transmitter, all this stuff. So now they actually have two new sensors. One's called the Simplera, which is actually made by Medtronic. It lasts 7 days, I believe. And they've partnered with Abbott to use their Libre sensor, but it's called Instinct because it's going to be made special for their pump. But it still is the Abbott sensor, which I believe is at 14 days, 15 days?
14 and a half days, I believe.
So really kind of big news, because for two reasons, I think. One, this interoperability of CGMs and pumps, that now are having more choices. If you're on the Medtronic, you can be on this or that sensor, or, it used to be you kind of were locked in. So that's a big deal. Two, I think it makes Medtronic a real contender in terms of an option for people to be on for a pump, because the algorithm is super good. And now if they have a sensor that, kind of works with it, that would be, fantastic.
Yeah, I mean, it's a big,
turn on the timer for us, Eric.
Oh,
sorry.
It's live. That's right. This is live, so we'll mess up all the time. It's a big deal for Medtronic because no one ever argued that they have a good pump. Their 780Gs, as you mentioned, is an excellent algorithm, but their sensor just wasn't very good. The form factor. So now there's three choices.
Yeah.
You can stick to the the Gen 4. You can go to the Simplera, which has a form factor similar to like a Dexcom or a Libre. It just lasts 7 days. It's a tiny bit bigger. Or you can go right to the Libre, now called the Instinct. So it's a big deal for them. And you're right. It's an excellent system now because it's got a great pump, algorithm, and sensor.
I've been told here the Instinct is 15 days. So that's one more than 2 weeks.
Who's telling you that?
All right. Do I really need a glucagon prescription? We'll do this one quickly. Yes. And I think this comes up sometimes, maybe kind of in the olden days, because the glucagon would expire after 6 months. People got tired of refilling it. They would say, I don't need it. I haven't used it. But trust me, as two endocrinologists, people that are living with type 1, we've both had to use glucagon on multiple occasions. So we're not like the end all be all for diabetes experts, but we know what we're doing. And if we've had to use it, there's a good chance that you might have to use it at some point in your life. So there's several options now. Do you want to talk about those real quick?
I want to say one more thing is that, Jeremy's referring to self-administration of glucagon.
No.
In the olden days, that's 3 times. In the olden days, it was like, that was blasphemy. You had to be out of it doing the fried egg. Someone else had to give it to you. So now we have the Gvoke HypoPen, which is like an EpiPen. You pull off a cap, you jam it in any place. So there's no time wasted compared to the old, erector set, chemistry set kit, which we did a great video on that. And then we have one that you take through the nostrils. I believe that's called Baqsimi.
Mm-hmm.
So both devices work well. There's pros and cons with each one, but the bottom line is, the other thing I just want to say is, a lot of people say they don't need it, like you just said, but it's like when people in their houses, they don't have a burglar alarm until their house gets burglarized. And anybody on insulin, especially type 1s over 10-year duration, especially because we lose our response to glucagon and we have hypo unawareness, at least in part. There's always a first time, and Murphy's law, the time that you have it, you may not have it with you if you don't think you need
Yeah.
it.
So get a prescription. And I was going to say these last like up to 2 years now. So you don't feel like you're having to get rid of them so frequently, but please have them. And importantly, show somebody else that you live with where it is. Because if you are having a seizure or you passed out, it's not going to do you any good that you're the one that knows it's on the top shelf of the closet. You know what I mean? You got to make sure that your, significant other, family, whatever knows. All right. I'm going to skip over this one a little bit because it's such a broad topic. So it says, is there research being done for type 1 diabetes to find a cure? And that is a whole 45-minute, discussion, which we actually did. We did a podcast right here with Dr. Aaron Kowalski, who's the CEO of formerly JDRF, now called Breakthrough T1D, talking about this specific topic, everything that's going on in islet cell transplant, new like gene therapy approaches, other things are going on. Oh, and immunotherapies to prevent type 1 diabetes, to halt the progress once you get it. So it's such a broad topic. The answer is a resounding yes. And it's actually research that continues to kind of pick up in a really exciting area.
Yeah, and just watch the video on our website. But when you look at the advancements in type 1 in this area that you're just asking, it's like going up like this. It's like we can't keep up with all the research and studies going on in type 1, pre-type 1, with affecting the immune attack, to just after your diagnosis, to folks like us that have been type 1 for a long duration, replacing our islet cells. And don't forget gene therapy, which is an amazing new area. And keep your eyes and ears open for a podcast we just did.
Yeah, we just did one with an expert in this topic of basically enabling us to deliver an insulin gene into muscle tissue to allow the muscle to essentially secrete insulin, which is amazing. And you can do it potentially without needing immunosuppression or these things. So this term gene therapy we talked about seemed like it was always over there. It was something happening to, these 1 in a billion type rare diseases. It's coming to more common diseases like type 1 diabetes, which is really pretty amazing.
Yeah, it's not Jordache or Levi's. Yeah, it is real genes. It's not joke. That's my own joke. Yeah. It's not islet cells, but it's the gene that makes insulin. And to spare you all the details now, you'll hear it on the podcast. There's other autoregulatory science behind it that helps secrete just enough insulin to turn on and off when you need it.
Yeah. So please don't laugh at Steve's gene joke. And if you did, don't let him know, because we're trying to bury that one. But all right. Another kind of big theme that maybe we'll set up and then get into the specific questions about it is, and this is a really cool, important area in type 1 diabetes, is the idea of non-insulin therapies in type 1 diabetes. I would say the most questions are specifically about GLP-1 medications, which you all know about if you turn on the TV or you ever have opened a newspaper. Things like Ozempic, Mounjaro, these drugs that we've been using for a long time, actually since 2005, in people with type 2 diabetes and obesity. And the issue, quote unquote issue, is that they're not approved yet for people with type 1 diabetes, which means that we actually know that they do work, and your provider can prescribe it for you. If it's not approved, it just means that it makes it more difficult to get it covered. And we can talk about tricks to get that done. But Steve, tell us, are these drugs something you can consider for every patient you see with type 1 or certain subsets? Like, who do you see that you're like, you should be on a GLP-1?
Yeah, and we have about 20 questions on that on the list. So that's why we're going to give this little tutorial. And when Jeremy says GLP-1s, he also means the GLP-1 GIP dual agonist. And that's the product by Lilly makes.
That's what I said, Mounjaro.
I know, but it's more than a GLP-1.
Okay.
I gotta teach the youngins here. The way I look at it is this: the drug is really initially approved for glucose control in type 2s, cardiovascular risk reduction, and obesity. You probably have a lot of friends that you say, whoa, you just lost 30, 40, 50 pounds. They're probably on one of these drugs. And so I think weight control is extremely important. And as Jeremy always points out, that over half of us type 1s in this country have a BMI over 25, 26. So we are getting heavier and getting...
that just means that most type 1s are officially either overweight or obese. That BMI of 25 is the cutoff for being overweight. So if you have type 1 diabetes and you're struggling with weight, you're not alone. And this is far from just a type 2 problem. We know it's a problem in type 2 diabetes, but it's also very much a problem in type 1.
Yeah, I'm 24.9.
Oh, great.
Okay.
You don't need it.
And you know what? When you're heavier, it leads to lots of other issues, insulin resistance. We know that fat can go into your liver and cause fatty liver, et cetera, heart disease. So I think it is an important issue. So I think weight is number one when I see a patient in clinic. I do have a patient, or I know of a patient who has obstructive sleep apnea. And we know that Mounjaro, Zepbound, the same thing, just one different indication, is helpful for people with obstructive sleep apnea. So if there's a special indication, like fatty liver disease with Ozempic, that could help your doctor, go to bat for you to get the drug approved. But I think the tips that we're going to give you, at least they might be a little bit different, is that when your doctor writes a prescription, it's specifically for obesity.
Yeah.
Never mention the word type 1 diabetes.
I'd say a couple things. In the clinical trials they've done to date, like these meds generally lower somebody's A1C by 0.3, 0.5%. So it definitely helps with glucose control, less kind of variability. People use less insulin, usually around 20% less or so. And then the weight loss is definitely there. The higher you go on the doses, the more weight that you lose. Your provider can prescribe this. And actually, a lot of the times I'll say that, the patient actually has type 2 diabetes, because people with type 1 have insulin resistance and problems with weight that we kind of call type 2 diabetes. So that can help get it approved. You can also write it for diabetes type 1.5, parentheses, treated as type 2. And I'm just telling you these specifics because there are ways to help kind of grease the wheels to get these drugs approved.
Yeah.
And Lilly and other companies are actually doing the larger clinical trials now to officially get this approved. So these tricks hopefully will only need for another 2 to 3 years before it's actually approved, and you can just kind of ask for a prescription.
Yeah, right. And they're expensive. So that's why you're always going to get pushback from the pharmaceutical, from the medical from your insurance company. And I would say I've never had one approved right off the bat. So asking for a prior authorization is a normal thing to do. And your doctor has to write, has to write a strong letter. You can help him. You can help give the information he needs to write a strong appeal.
Yeah. And so now some specific questions. So one of these is, where are we at about getting them approved? We'd say, a couple years away. As a long-term type 1 with gastroparesis, how can I discuss whether GLP-1s might worsen that? So gastroparesis is a condition where you get kind of delayed absorption of food. It can make you nauseous. It can make you vomit. And GLP-1s can further slow down kind of your gastric motility, but not to the case where I would say if you have any gastroparesis, you shouldn't try GLP-1s. Steve's actually of the opinion that sometimes it can make it a little bit better in the right patient. So I would say if you even have gastroparesis or this is a condition you have, you still could try it. Now, the final thing maybe we'll say about this is that when type 1s go on these meds, I find that they typically need to start at lower doses than we start for type 2s and titrate up much slower because of these gastrointestinal side effects like nausea, very rarely vomiting. But you got to start low and go slow.
Yeah, no, that's great advice. Who's your mentor?
I don't know. He's not here.
You know what? And there's other reasons why type 1s may need lower doses. But recently in June, there was an announcement of a big study in type 1s that all these type 1s were on hybrid closed loop systems, started on Ozempic, and then there was a placebo group, and they they got up to, the plan was to go up to 1 milligram a week. And as you know, or you may not know, Ozempic goes up to 2.4 a week. And a lot of those patients never even got to that full dose of 1. And they had great responses with no adverse events, no increase in hypo, no diabetic ketoacidosis. Some people were afraid that might be an issue. No issues with GI side effects. But once again, with a gastroparesis, if your gastroparesis is not too bad and really kicks up when you overeat, you take a drug that prevents you from overeating, you're going to do better. So well said.
We've done I think we've done podcasts on this topic because it is something that I think we're very passionate about and can really help. So don't feel sheepish about asking your provider for it. And if they say that's not for type 1s, don't accept that answer. Like we really are using these drugs more and more. So anyways,
you got to be persistent and be your own self advocate.
Yeah. So let's switch categories a little bit. I'd say the other major category is just kind of technology in general. So we'll go through some of these rapid fire. What pump options or bolus strategies work best for swimming? Well, it kind of depends on what you mean by swimming. Because if you're in the water all the time for hours a day, like you're semi-professional or whatever, you're a real swimmer, then really the only option is something on the body like the Omnipod or the Tandem Mobi, something that you can wear while you're swimming for these prolonged periods of time. You don't want to go without insulin for, generally we say, more than 30 minutes. If you stretch that out to an hour, maybe you'll be okay. But if you're in the pool for 3 or 4 hours, you're going to need some kind of insulin. Now, for the casual swimmer like me, Steve, whatever, you can kind of wear anything. We
go skinny dipping.
Yeah, all the time.
We don't wear anything.
And you can, depending on how long you're in the water, you could just, disconnect and jump in. Sometimes I'll give myself like a little bolus, like a unit or so to kind of carry me over the period that I'm, in the water for 30 minutes or so. Same kind of thing with showering. So that's kind of big strokes picture for that, I would say.
Yeah. I have a patient. She swims for San Diego State. She's a water polo swimmer, and she wears the Omnipod, and she also puts on a cover up of it because she's in the water for many hours. And I think anytime you're in the water for that long, even for your CGM, you should get a cover up that you can get online, and that really helps keep it on.
Yeah.
And if you think disconnecting for a long time is okay, because when you hook up again, your blood sugars are good. It typically you're basically under insulinized, and your response to the next meal will be postprandial high. So it's not really good to disconnect.
Yeah.
And, if let's say Jeremy's blood sugar is 220, he takes 3 or 4 units as a correction, and then you can take it off for quite a long time because that insulin hangs around. But then it's like a crapshoot. Are you going to get low? Things like that. So yeah. And the twist is out too. And the twist is a little bit like the Mobi, that it's very small. Even though it's a tube pump, they're going to have some systems where you can tape it to your body.
Yeah.
And it's going to also hook up with the Eversense, and the sensor is implanted under the skin. So, there are choices out there.
And I know this specific question was about swimming, but we're kind of getting in this territory of which system is the best. We hear that all the time. Which pump should I be on?
Give me your spiel.
And there is no best pump. They all have their advantages and disadvantages. There's tubing, there's not, there's, the algorithm, there's the CGMs that it works with. There's maybe insurance coverage, like considerations or out-of-pocket costs, all these things. And literally, different patients, I'll see whatever patients for a morning, and I'll have a patient on every different system. So I'm not someone, I know you're not too, where it's like every pump, or there's one pump for every single person. So do your homework, research the systems. We did like a speed dating thing that was super popular, where I kind of speed dated each pump. But the idea there is really kind of like investigate the different devices. Our good friend David who does a tech blog, talks about, don't be married to your pump, be like in a promiscuous relationship, I suppose, is like his advice.
Well, he gave a lecture at our face-to-face one conference. We also taped. It's online. And he did a TCOID live that is not that out of date. We have a really good article in our newsletter about the different systems, and even in the speed dating video, we have charts and graphs. But what I always say is, I have patients that they could be on the best system in the world and their time and range is not that great. And you can take someone on an older system that may not have all the bells and whistles, may not have the best algorithm, whatever that means, and they time and range 85%. So I always say that, you have the system that accounts for 70 to 80% of your control, and the rest, the 20, 30% is you.
Yeah.
Because anybody can mess up a CGM pump combination, hybrid closed loop system.
Well, and for people that are playing the shot game at home, they're on the ground by now with all the shots that they've had to take.
By the way, that's one of our favorite videos is when we went to my house and we talked about drinking alcohol safely.
Yeah.
And
so check that out online. I had to drink 3 IPAs in 45 minutes, and he drank 3 old fashions. And we talk about the different effects of alcohol on your blood sugar, effects of alcohol on you. You start, obviously you're not quite as with it and smart and things like that, but also the effects of the alcohol on your blood sugars. Like there's a lot of carbs in beers. My blood sugars went up. There's no carbs really in old fashions except for the cherries that Steve wouldn't shut up about being in his old fashioned. So anyways, it was actually very educational and very entertaining. So other Omnipod this is a technology. This one is specifically about the Omnipod. They're worried about flying. This used to be a thing like people would talk about a lot in pumps in general. With pressure changes up or down, is that affecting my pump? How do you tell people that?
We recently did an article on that, so I'm up to snuff on that. It turns out that when you ascend going up, the cabin pressure drops, and if you have air bubbles in your reservoir, it could actually the air bubbles expand and push insulin into your body. It's the opposite on the way down, and it especially affects people with the the Omnipod because there's no tubing, and any expansion is magnified, or I should say, if you have tubing, the expansion of the insulin is diminished because the tubing is so long. And so I'd say the best thing to do is when you fill up your Omnipod, really, in that syringe where you're about to shove in insulin to the reservoir, get all those bubbles out, and don't be real cheap with your insulin. Don't try to squeeze every bit of it in. Just, when you see the plunger getting close to those little air bubbles, just stop, because you'll have enough. All you need is 100 units, and it holds 200 units. And if you can get to 175 and not push every last drop in. And I've heard of other people saying they suspend their insulin delivery for like 15 minutes, gives a chance to equilibrate. Once you get to an altitude of 30,000 feet, the flight attendant's giving you your beers, and everything should be a little better. Turn it back on. That's an unproven technique.
I mean, my take on this is we talk about this all the time. Most people have no issue whatsoever or even notice it at all. So, I mean, you use an Omnipod. Is this like something that you think about when you're taking off or landing or?
It did happen to me once, so now I pay closer attention. And at one point, Southwest Airlines had a warning on their website. I'm not sure if it's still there. And I have a patient who flies for JetBlue, commercial airlines. He's got a Type 1, very inspiring for us Type 1s. There's like 5 Type 1 commercial pilots, and the FAA will frown on him using a hybrid closed loop system because of this exact issue. So he's on multiple daily injections. He's doing great, but he's hesitant to even attempt to try to talk him into it because, he likes his job. They're super strict, and I think that's really good to hear.
Yeah.
They're very strict, and they know everything about time and range, time below range, and he has to turn in his CGM metrics every month.
Well, we also did a good video on traveling with diabetes, type 1 diabetes. That is popular because some reason I ended up kind of like naked when I was going through. I had to go through the scanner multiple times and everything was beeping, so I had to take off my shirt. Steve was the police officer guy, and then my pants and everything. But we go through all this. How do you pack for trips? And half of our bags are filled with diabetes stuff. A big take home was always take duplicates, because if something's going to go wrong, it's when you're out of the country or whatever. I can't tell you, like I've done this several times when I've been in a hotel room and just dropped my vial of insulin on the hotel bathroom floor and just seen it crack open and this liquid life pouring out of it, and you're away from home. So anyways, that was a good video, but just like a lot to think about when you're packing for these trips, including now, I guess we got to worry about freaking taking off and landing.
Well, I take extra for me and a couple extras for Jeremy.
He does.
Hey, Jeremy, what'd you forget this time?
Exactly.
But he wasn't really naked. Eric, our ultimate producer, director, videographer, blurred it out.
Yeah.
So for you,
Well, you don't have to tell them that. Now they're not going to watch.
but you still can see the edges of it.
Stop. Jesus. All right. Here's another tech-related one. This is a specific question, but a good one. So, will sleep mode on 24 hours work on Control IQ to help with my blood sugars? So let me back up. So the Tandem system called Control IQ, you can put it in sleep mode, and you're kind of supposed to do that when you're sleeping. You set it for, let's say, 9 p.m. to 6 a.m. every day. And while it's in sleep mode, it targets a slightly lower blood sugar. So it's slightly more aggressive with trying to bring your blood sugars down into range. It figures you're sleeping, you're not active. This is kind of a safe time maybe to kind of bring you down into range. But when it's in that mode, it doesn't do any like auto corrections if your blood sugars are going high. So people will say one way or the other. Should I put it in sleep mode for 24 hours? Should I not have it on sleep mode? I've always just said put it in sleep mode when you're sleeping, but you can fool around with like trying it either way. I honestly don't think it makes that much of a difference.
Yeah. Tandem is a good system. It's been out for many years. And in my experience, we have a lot of people on the Tandem at the VA. That's one of the few systems that we get for our type 1s there. And it's trial and error. I got some patients that love sleep mode and they keep a close eye. And if they need an extra bolus, they'll give it themselves. And other people, it works better if they put on sleep mode. So it's like anything else. And what we talked about earlier, find out what works best for you. And you sleep between 9 and 6.
I'm just saying as an example.
Okay.
All right. Is it true that you can only stay in range if you are on a pump, whereas you can't get the same results with pens or syringes? So, broad strokes, when you look at people in the United States, whether they're on pumps or syringes, in general, people on pumps and hybrid closed loop systems tend to do better. They have lower A1Cs, they have more time in range, they have less hypoglycemia. However, for any given person, it depends. Like Steve said, you got somebody on the best of the best not doing well. You got somebody on syringes doing really great.
Mm-hmm.
So you can do well on syringes. And we always say, if it's not broke, don't fix it. If you're doing, a basal bolus regimen and your time in range is above 70%, you're not having hypos, and you like kind of the freedom of not being on a pump, well, then great. But, if you're not meeting those goals, don't let months, years go by. I still have patients that'll say, I want something on my body. I don't want to be tethered to something. And I every visit, I'm just trying to get them to at least try it, because of all these systems, there's usually like a 30-day free trial period.
Yep.
And guess what? Even if you go onto a pump, you take it off, you take your basal injection of Lantus or Tresiba or whatever, and you're right back to where you were. I think there's this idea that people have, if I try a pump, then I'm a pump person forever.
Yeah.
So, and vice versa. If you are on a pump and you want to, take a break and go on shots, do it. I do that from time to time when I go on vacation, especially when I'm in the water, and then maybe I'll try a basal insulin, things like that. So, have some flexibility with your regimen.
Yeah, I'll just add a little bit to it. I agree with Jeremy totally. In the olden days, when the pumps did not communicate with the CGM, we called those dumb pumps. We used to give lectures, it doesn't matter, pumps or multiple daily injections, doesn't matter. It's up to you. But the fact now that the pump communicates with the CGM and gives you automatic insulin delivery, trust me, these systems make way better decisions than you do. Bolusing and giving yourself corrections while you're sleeping during the day. So it's very hard to do as well. However, saying that, I have a lot of athletes that do not want to wear a pump, or people that just don't want to wear a pump in general, and they do really well. But as Jeremy said, if you're not doing that well, you should really, open your eyes and your mind to trying it.
Mm-hmm.
And I don't think I've ever had a patient go off it once they tried it. And because, a lot of people are afraid to give up control. You got this little device giving you insulin that could kill you if it gives you too much. And I have not heard of a single case of one of these hybrid closed loop automatic insulin delivery systems causing severe adverse events in terms of hypo. Have you?
No, but in fact, it's quite the opposite. They've been proven to reduce hypoglycemia
right.
and to keep people safe. I mean, that's been proven kind of over and over again. All right, this is one that I know you're passionate about, Steve. So it says, my question is why my A1C when I go to the lab is above 8, but the Dexcom app estimates that the A1C is at 7. So,
Okay.
Well,
Well,
for it.
the A1C test sucks. That's the bottom line. If you all can follow me on this, when you get your blood drawn, it goes to a lab. There's a big machine. It has an assay, and it has to be calibrated. They have to get chemicals to make sure it's accurate. The assay itself is not calibrated between labs across the country, and I can tell you for sure this has happened to me several times where my estimated A1C or GMI is like 6.9 and it came back 7.5. And that's embarrassing because all the residents are seeing how well I'm doing at the hospital. I'm serious. I called Rob Fitzgerald. He's head of our lab. He sends me a paper and he says this, that I hear you, Steve, but you send your blood to 5 different labs, you can get a difference of 0.7%. So I get people that say, oh my God, I'm getting worse. I was 6.9 and now I'm 7.0. Trust me, that's not a difference. So the assay is terrible, but your estimated A1C is based on one thing, your average glucose. And there's a lot of things that can affect your A1C, like anemia, different type of ethnic groups, certain diseases like kidney disease.
Yeah, and I'll add that there are patients where it's just clear that particular patient has a discrepancy between their A1C and their blood sugars. And sometimes, a lot of times we don't know the reason.
Right.
And we just write in the chart, this is not, representative, this is not accurate. But then, like you said, that you're embarrassed, but sometimes patients will go and they need a transplant or some surgery. And the surgeon will say, I'm not going to do it until your A1C is less than 7.
Yeah.
So it can be an issue.
Yeah.
But always relying on the CGM because that never lies.
Yeah, that's true. And the one thing that's very upsetting to me, I asked him if he could take the 7.5 or 6 off my lab on the electronic medical records. He couldn't do it. Why? It's inaccurate. They could not delete it.
Well, I'm going to tell everybody to look at it. Just so
I mean, 7.5 isn't horrible, but it really was upsetting to me. And
you'd been working hard. I remember this was like a real, you were proud of how your blood sugars were doing. You were going to the lab to get A1C to kind of confirm it. And then you got kind of slapped in the face.
And there's something else strange that I can't explain. I don't think anybody can explain. It's always about 0.5, 0.6 higher in the lab than it is on my CGM. And that's just something particular with my blood and my, issues. So, yeah, that's the answer.
All right. How do I handle insulin carb ratios? This is in general. This particular question was about a specific pump, but in general. So, to be honest, you get it kind of in the ballpark of where you think it should be. Most type 1s fall between somewhere in an insulin carb ratio of 8 to 15. And I find, however, that the pre-bolusing, the timing of the bolus matters way more than getting kind of the carbs right or even the carb ratio exactly right. So I talked about before that usually 20 minutes, maybe 30 minutes before I eat, I'll just put 30 grams of carbs into my pump for pretty much every meal. So I get insulin.
Don't listen to this.
But that's a great, you should do this. And that gets something going, some insulin in your system. And I typically eat more than 30 grams. But that pre-bolusing is way more important than entering the right amount of carbs at, right when I start eating. Because if you wait till right when you start eating, doesn't matter what you enter, you're going to have a high spike because it takes insulin so long to start working.
Yep. No, you're absolutely right. Having that pre-bolus and before you eat really limits how high your blood sugar rises after eating. So, I couldn't agree with you more. Now, I was brought up on the exchange system. Then, eventually came, carb counting. And I never was good at carb counting, but it turns out that in these hybrid closed loop systems we're talking about, the 5 approved on the market, the insulin to carb ratio is one of the most important, settings you can put in your system, along with, your total daily dose, other things. But I go about it backwards. I'll say real quickly.
Well, I would just say, I want to give people a formula. If you want to know an actual calculation that we use, you take 500 and divide it by your total daily dose of insulin. So if your total daily dose of insulin is about 50, then 500 divided by 50 is 10. And your carb ratio, that's like generally how we kind of start people on their pumps. And we modify from there. So if you want to see you're in the right ballpark, just use that formula and then you'll figure it out.
Yeah. And what I do, I look at it the other way around. I've been taking insulin on my own guesstimate for a long time. And for meals that I know I need, like, for example, 5 units, I give 5 units. Well, how do I enter that in my pump, my hybrid closed loop system? My ratio is 1 to 10. So I put in 50 grams of carbs. I know it gives me 5 units. So I go backwards. So I know I need 5 units. And then you can manipulate that and learn. You can do the calculation that Jeremy just told you as a way to start off, which we do when we start people on pumps. So it's a combination of what you normally take. But I think it is good to find out approximately what your insulin to carb ratio
the
is.
swag method. It's a sophisticated, wild ass guess. But the key there is it's sophisticated. All right. So let's keep moving on. Do I need to remove my Dexcom and Omnipod before dental x-rays? No. And you don't need to remove it for,
Well,
going through.
what if they wear their pod on the inside of their cheek and gum?
Yeah. If going through the scanners at the airport, all that kind of stuff. So I have a lot of scar tissue and experience post-meal highs related to absorption. Would you consider a patient to use a pump with Humalog for basal and then inject Lumjev for faster absorption? So, all right, there was a question later too about, what to do with these post-meal highs or stubborn high blood sugars. Is there anything else you can do? I'd say the two most effective things are, one, the pre-bolus that I already mentioned,
which is hard to remember to do.
It's hard to remember, but it's not the end of the world. And then two is Afrezza. So this person actually mentions Lumjev, which is like it's a rapid acting injectable insulin that is like this much faster than, Humalog or Novolog. Afrezza, the inhaled insulin, is very rapid on, very rapid off. To be specific, when you inject Humalog or Novolog, it starts working in about 30 minutes. It peaks in about 2 hours and it hangs on for 4 or 5 hours. Versus Afrezza, which starts working almost immediately and peaks in about 15, 30 minutes, and then gets out of your system in 90 minutes. So it's this real kind of razor sharp tool that you can add to anything. If you're using a pump, you can use it occasionally. If you're using multiple daily injections, you can use it. So ask your provider about it as like an additional tool in your toolbox.
Yeah, we've done multiple videos on it. We both use it ourselves. And, the videos are not only how to be your own advocate and ask your doctor, because your doctor probably won't know much about it. It's easy for them to say, oh, you don't need it, but also the proper dosing of it.
Yeah.
And so Jeremy did a great video on that on our website on how to dose it. It's not the same as sub-Q insulin, but I think it's one of the best tools we have to treat post-meal blood sugars. And I'll just say a quick word about lipohypertrophy. I think that question had it. If you're a creature of habit and you put your insertion site for your pump or your Omnipod, or you always inject in the same spot, you're going to get some fatty tissue buildup that could affect absorption. So if you can avoid those spots, and you may be running out of spots, but that's one reason why some people like the Omnipod, because it allows you to reach other areas. I put my Omnipod.
Well, this is a question. It says, I find that my Omnipod doesn't absorb as much on my arm. Are there other suggestions for sites? So,
oh wow, perfect. Here, can you pull down this shirt so they can see it?
I think your arm's too big for me to get this shirt around
so
it.
So believe it or not,
a
lot of people are surprised.
I'm surprised.
A lot of people, but basically I put it on my upper back, about halfway between the outer arm and my vertebrae, and I love that spot because it doesn't get knocked off, and everyone has a natural curvature to their back, and so you can sit against a chair, you'll never hit it. But once again, you can experiment. The companies always tell you to put for example, your CGM on your arm. It doesn't need to be on your arm.
Yeah.
You can actually put that on your cheek and it'll probably work fine. You can put it.
I mean, it's important to say this is where they generally did the initial studies, and that's where they got the official approval. And when it's officially approved for something, that means that that's all the representatives can say. They can't say something off label, but you can wear a CGM and a pump anywhere you have a little bit of fat, which is most places on our body.
Yeah, and you wear a tube pump now, the 780. Before that, the Tandem. You use your thigh to put the infusion line on.
Yeah.
He's just ashamed. But when he had to pull down his pants at the airport, it was very embarrassing. In fact, that's why it went off. That's why the TSA agent, had beep.
We had so many things.
So experiment.
Yeah.
Like Jeremy said, subcutaneous tissue is all over our bodies. And, I am pretty muscular up here. You have to admit. And the catheter is only this long.
Right.
So you don't have to have a bunch of fatty tissue.
Yeah. Great.
Eric's laughing.
Some other questions about Afrezza, just to round that topic out. Is it easy enough to get? Well, it's like everything.
It's extra hard to get.
You have to go through an approval process. Sometimes they'll have to say, for example, like lipohypertrophy is something to say that you have because it affects absorption, or you have frequent highs or lows, or you have a needle phobia, something like that. You usually have to do a lung function or a spirometry test. Just breathe into the thing for 1 second to make sure you don't have any underlying lung disease. It doesn't cause lung disease, but they want to make sure you don't have undiagnosed emphysema or something like that. So if your doctor, a lot of times your provider, though, when you say Afrezza, will just look at you like you just, they don't know what you're talking about. So if you get immediate pushback, like, no, you don't need that, chances are they don't know what they're talking about.
Yeah. Here's the best suggestion. To try to get your doctor to call the Mankind representative.
Mm-hmm.
They have great tips, and there are certain pharmacies that deal with Afrezza much better. CVS is the kiss of death. They'll always reject it right away, charge you twice as much. We're trying to get sued by CVS. It's the best publicity. It's free. It's organic. But
all right. Sorry. We got 7 minutes left. So we're going to do rapid fire.
Okay.
Blood sugars aren't coming down. What else can I do? So we mentioned Afrezza. That's a good one. As a type 1 taking Humalog and Tresiba, I exercise regularly, eat small meals. How can I safely lose weight without triggering hypos? Well, I think going on a pump would be one thing. Starting a GLP-1 potentially. We've done a lot on exercise and diabetes in general on our website.
My one comment is reduce your insulin first by 10%, something like that. Then start exercising. And then you may be slightly high for a short period of time. It's not going to cause any complications. And then go back up on the insulin as needed, but cut the insulin back first so you can avoid hypos.
Could the delayed rise my blood sugar glucose after I eat without digestive systems, could that be gastroparesis? Probably not. It could be, but everybody has spikes after meals. So I don't think you need to go necessarily looking for another cause other than our insulin acts really freaking slow. So we actually have done a podcast too on fighting how to fight the spike, ways that you can attack the post-meal blood sugars, which is everybody's probably biggest frustration.
Strike the fight, not fight the strike.
No, strike the spike.
Spike the strike. Okay, keep going.
How do you control the urge to overtreat a low? Oh my gosh. Is there ever a time when 15 grams of carbs and weight isn't enough? Well, first of all, it's impossible to fight the urge because your body is telling you literally you're dying. So the only thing that I've found helpful is the kind of worst instance is when you're sleeping, right? And you have a bad low, you get out of bed, you eat everything in the fridge. So I just keep a small little apple juice by my bed. I drink that and I go back to sleep. And I know that, if I drink that, it's enough to treat my low blood sugar and I can get on with my day. But if you get out of bed or if you go to the fridge, it's over.
If you get out of bed, you're dead. You know what? When I go to the fridge, I eat everything in there, but I do what you do. I have apple juice right by my bedside. Do not get out of bed.
Yeah. Should I be concerned about how much fast-acting insulin I use every day? For example, could I eat a low-carb salad and not take much insulin? Yeah. I always tell people that you take the amount of insulin that your pancreas would be making. So if you're eating completely low carb, you don't need to take, fast-acting insulin for that. If you eat a giant pasta meal, you need to take a bunch of fast-acting insulin, just like your pancreas would do.
And hopefully you got a CGM so you can just watch what's happening.
I've heard that exercise can have negative impact on blood sugar levels, making levels go high. Is that true? Overall, exercise is good for you. No doubt about it. We did a whole thing on this too, in terms of mood, sleep, your fitness level, cardiovascular disease. However, it can be difficult to exercise with your blood sugars, with sometimes it causing you to go low, sometimes having spikes after exercise. Again, we did another great video where I was on a Peloton for 45 minutes, and Steve, because he's a little bit of an older gentleman, was just on a treadmill because he couldn't keep up.
3% angle too.
But we talked about the effects of like high intensity versus low intensity, how to prepare for exercise. You always say it's one of the most difficult things in type 1 diabetes to deal with.
Totally.
Still good for you. So try to work on how to figure out how to do it, but it can be, erratic blood sugars.
Yeah. We can talk about this. A whole show on exercising, but for example, as one example, people that don't put their pump in exercise mode an hour early before they exercise, they typically get low if they just put it on exercise mode and then go out running. So there's a lot of tips of the trade. We did a great video on this, and Jeremy and I tried to go in with a perfect blood sugar. He messed up, I messed up, and everyone that watched it loved the fact that we doing, even though we knew everything, it's not always easy to keep your blood sugar in a safe range before, during, and after exercise. So it is difficult.
3 minutes. We're going to do as many as we can. I struggle with bolusing for fat and protein. My blood sugars go up 2, 3, 4 hours. Any advice? It's tough. Keep an eye on your CGM, multiple little micro boluses for fat and protein. There's no real good scale.
There may be someday, but this is where a hybrid closed loop with proper settings will help take care of that with automatic insulin delivery over those 2 to 3 hours after eating.
Proper way to control low blood sugar without risk of having a high sugar later. We talked about that. How do you use mini dose glucagon? Not to refer you to a podcast, but we did an entire podcast on that. That's taking little units of glucagon. You can do it before exercising to treat kind of minor lows. Here's some questions on statins. How does statins impact resistance? Is there a better time of day to take my meds? As far as I know, statins don't have any effect on blood sugars or impact insulin resistance. So in generally taking meds, I'm not sure exactly how to answer that. If it's about your insulin, like your long acting insulin, it's the time of day that you're most likely to remember it. You can take it in the morning, you can take it at night. But otherwise, we don't have specific time of day for people with diabetes to take their meds.
Yeah, well, with statins, they work the best when you take them right when you go to sleep. They lower your LDL cholesterol a little bit more than if you take it in the morning. And there is a lot of stuff out on the internet that it causes diabetes, a lot of crazy loons out there. So don't pay attention.
Yeah. And I think that question was more about because they might affect my blood sugars. And so anyways.
Right. But they cause, if they cause insulin resistance, they're going to affect your blood sugar.
Yeah.
And if we go 1 second over, don't.
Okay. Well, we got a lot of questions.
Well, let's go.
Okay. So please comment on statins. Can you give me specifics as to who should be on them? My general practitioner told me that I should be on it. Not ready to jump. So our goal is that for people with diabetes, we want your LDL, your lousy cholesterol, to be less than 70. And I always say that it's almost impossible to get there without medications. And when it comes to cardiovascular disease, cholesterol is arguably the most important thing that you can do to reduce your risk of cardiovascular disease. More important than blood sugars and potentially more important than blood pressure. And it's very easy to treat. I don't know why, but statins have gotten a whole lot of negative press. Try them. Most people have zero side effects for them. If you do, there's a litany of other medications you can try now to reduce your cholesterol. So please do something about it.
Yeah, nothing much to add to that, but you got to get your LDL to goal. Clearly been shown to reduce heart attacks and strokes. This is preventative stuff, so don't take this lightly.
Recently diagnosed with celiac disease. Do you recommend type 1s be tested annually, or what is the standard? We don't really have a set standard. We definitely, look out for symptoms. Celiac disease and thyroid disease are the two kind of most common things that go with type 1. So we check thyroid function, I would say, every year. We generally don't screen for celiac unless somebody comes in with any kind of like gastrointestinal side effects. And we just have our kind of antenna up high.
Yeah.
If you walk in with type 1, you say, my tummy hurts. For any reason, you're going to get tested for celiac.
Yeah. Well said. Nothing to add to that.
So an emotional one. What do you suggest when you feel like you're a burden to others? When your blood sugars are up and down, the alarm goes off so many times, and then you have a bad diabetic episode at one time and the paramedics have to come. Gosh. Well, there's a lot there. And, a lot of what we do, in addition to kind of the medical stuff here at TCOID, is exactly this, the emotional side of it, that we spent the last 44 minutes talking about, A1Cs and LDLs and things like that. But the things that probably drive you guys the nuts is just this. It's not actually your blood sugar being high. It's that I'm doing everything I can and my blood sugar's high and I'm frustrated. And yeah, maybe I'm putting out my spouse or my best friend and they're concerned about it. So this is a real issue. We've done a whole lot on this too. We have a very good friend named Bill Polanski who lives here in Encinitas. He is a behavioral diabetes specialist. He wrote several books, one called Diabetes Burnout. Please look on our podcast for him or other people that we've done on these topics, because really we don't, talk about it enough.
Yeah, he has a website called Behavioral Diabetes Institute. and he has a partner named Susan Guzman, and they deal with this issue all the time. And from what you described, the medical part of the answer is, sounds like you're not on a hybrid closed loop system, and it would help with a lot of the frustrations of the ups and downs, but you still can get those on these systems as well. And I always say this, Jeremy, diabetes can really mess with your mind, frustration, guilt, depression, anxiety, distress, and it affects certain people more than others. So we have to respect the fact that, some people really suffer more from the emotional and behavioral issues. Reach out and get help. There's a whole cadre of behavioral specialists that deal with people with diabetes with issues. And I know there's a website. I think it was on the ADA.
American Diabetes Association.
Yeah.
You can find a diabetes specialist, behavioral specialist in your area.
Near you. Yeah. In fact, you might live next door to Bill. I hope not. But he's got some really loud dogs.
Well, we're sorry we didn't get through everything, but I think ending on a positive note is that we always say people with type 1 diabetes are living longer than even people without diabetes. And a lot of it is because of exactly what you're doing right now. You're tuning in to learn about your health, and not just your blood sugars, but what did we cover? Exercise, your diet, other medications, cardiovascular disease, all these components of your health that we kind of put under the umbrella of diabetes. But you're here learning about these things, guarantee being a healthier person because of it. And the work that you're doing, pays off in terms of not just a long life, but hopefully a healthier, happier life as well.
Yeah. One of the famous quotes, Sir William Osler, the way to live a long and healthy life is to get a chronic disease and take care of it.
Mm-hmm.
And one thing, I was in clinic yesterday, and of my 7 patients, all with type 1, the youngest was 58. Most were over 60, 2 in their 80s. And I said to the resident and our fellow, I said, look at this. These people are all doing well. And in the olden days, they never would have lived this long.
Yeah.
So it's a different era now. And if you're not a type 1, you're a loser. That's our motto. We're going to stick to that. And we change our theme when we do the type 2 Q&A. But we really appreciate you coming on.
And kind of wrapping up, we're celebrating our 30th anniversary of TCOID that Steve started pretty much exactly 30 years ago.
Yeah.
October 10th. Check it out on our website. We're actually having a fundraiser right here. Literally right here, in San Diego. So if you're in any in the area, or if you want to fly in for it, please do. But like we said, this is live. So we take the questions as they come in. A lot of good stuff. And if we didn't answer it, I don't want you to feel unanswered, because we literally have everything on our website. Like, you think about a topic that has ever popped into your mind. If you go to watch and click on the video vault, you can see all the different categories of videos that we have there. You can click on listen to our podcast. Very well organized in terms of the topics. You can pick the ones that you want to watch. So please take a moment to do that, because it's important. And continue to support us. And the best way that you can do that is to do all the social media stuff. Like us, follow, subscribe, share this with friends. And then, of course, if you are in the giving mood, you can always donate on our website. But those things absolutely, literally keep us going. So thanks for tuning in. Hope you learned something. Hope you enjoyed it. Thanks for all the questions. And Steve, it's been a blast.
Yeah, thank you. Thank you all so much for participating today. And you can always see this recorded online and send it to friends as well. And anything you can do to help support the organization, we greatly appreciate it. One last
Yeah.
sorry, Eric, I just blew out Eric's eardrums.
All right.